Your baby's growth might be silently affected, and there is only one test which can detect whether the baby is growing well or not, that is a Doppler. What if I tell you that uterine artery Doppler can not only predict the growth of your baby, it can also predict the incidence of blood pressure and growth restriction in your baby later in the pregnancy. Hi, I am Dr. Rajat and I have used this uterine artery Doppler brilliantly to predict the high risk pregnancy and to take the preventive measures on a timely basis and give a good result, that is a healthy child and a healthy mother at the end of pregnancy. In today's videos, we will discuss about what is Doppler, why Doppler is done in pregnancy, what are the indications of Doppler in pregnancy, when to do Doppler in pregnancy, how to do Doppler in pregnancy, how is Doppler done, how much does it cost, what are the indications of Doppler in pregnancy, does an ultrasound in pregnancy cause any harm in pregnancy, and watch the video till the end. I'll give you a bonus tip as to most of the females, they do mistake. Whenever a doctor is prescribing them a Doppler, they get a simple ultrasound sonography done. For a general public, ultrasound and Doppler are same, but for us doctors, there is a world of difference between the ultrasound and a Doppler. We'll discuss everything in today's video. Hello, good morning, good afternoon, wherever you are. I am your host and host, Dr. Rajat, and you have started watching our YouTube channel, The Fertility Gynecologist. In last video, we talked about the various methods of antenatal fetal surveillance. What do I mean by antenatal fetal surveillance? The most important question in a mind of a female and a parent is whether the child is well inside the womb. Long back in 80s when the sonography came in India, the plain sonography, that is a B mode black and white sonography was being done. It was at least better than the clinical examination. At least we could see the head, we could see the fetal heart, we could see the anomalies around. But as we grew in our knowledge, as we understood the body better, as we understood ultrasound better, the newer advances came and so came the Doppler sonography. What is Doppler? Whenever a moving object is there in the blood, it throws some echoes, ultrasound echoes, and those echoes can be tracked by a Doppler effect. So a person who is doing an ultrasound can also do a Doppler because most of the machines nowadays have got a Doppler inbuilt facility. Yes, you do require a special training for Doppler, but by default, if we are sending the patient for an ultrasound, ideally a radiologist or a fetal medicine specialist should be doing a Doppler sonography. Most of the times when the fetus in the uterus is compromised, that means the fetus is not getting enough blood or a fetus is not getting enough nutrients, it shows and it is going towards the fetal hypoxia, fetal hypoxemia, ultimately fetal distress followed by fetal death. By doing Doppler, we can identify those changes early. We can also predict those changes relatively very early in the pregnancy, that this pregnancy would end up in likelihood of fetal hypoxia, fetal hypoxemia, or so that we can take the preventive and corrective measures very early on in the pregnancy. Doppler basically identifies the presence or absence of flow. It identifies the direction of flow. It identifies the flow characteristic of the blood vessels. In our obstetrics, we do basically three kinds of Doppler. One is for a utero-placental circulation, which I'll discuss in today's videos. Next is fetal-placental circulation, that means an umbilical artery Doppler, and other is fetal Doppler, that means middle cerebral artery, ductus venosus, and all those fetal cardiac Doppler, which we will discuss in the next video. So why Doppler is helpful in pregnancy? Doppler not only assesses the fetal growth and development. When we do a simple B mode sonography, that is a simple ultrasound, we just know the growth parameters. We have come a long way back from 80s and 90s. Now we are in 2020, mid 2020s. We have evolved, we have learned, and we have evolved. Just it is not important to do the anthropometric parameters, that what is BPD, what is femur length, what is abdominal circumference. We want to find out if it is less, why it is less, and whether this less will be there in the later months of the pregnancy or not. And because if we find out that there is a cause of fetal growth restriction or fetal is not growing well, can we do anything to prevent it? I for one firmly believe it is not only important to diagnose, to predict, but it is important to prevent the complication. And Doppler is a very handy and a very helpful tool for me to prevent the complication. If I am not able to prevent the complication, at least I can delay the complication. And even if complication occurs, I can decrease the intensity or the severity of complication with the use of Doppler. It is such a helpful tool to me. So the number one use of Doppler is it assesses the fetal growth and development. Now fetus receives its nutrients, the oxygen and blood from the placenta. And studying the utero-placental circulation and studying the fetal-placental circulation gives me an idea about the placental insufficiency, because the late causes of or the early causes of fetal growth restrictions are because of the placental insufficiency. Doppler also helps me in identify the high-risk pregnancies. Any patient who is diabetic, who is chronic hypertensive, severe preeclampsia, gestational diabetes mellitus, oligohydramnios, multiple pregnancies, IVF conceived pregnancies, autoimmune clotting disorders, in all these cases, Doppler helps me. It also helps me regarding the umbilical cord. Sometimes there is a loop of cord around the neck. The cord get compressed or there is a vasa previa. Doppler helps me identify, it helps me plan a delivery well in advance, whether I should go for a normal delivery, when I should go for a normal delivery, or I should terminate the pregnancy. It also helps me in taking the decisions regarding the delivery. If Doppler is abnormal, NST is abnormal, I have to take the baby out irrespective of the maturity of the baby. If I am not going to do anything, baby will die inside the uterus and I cannot do. At least if I take the live baby out, even if that baby is 26, 27, 28, 29 weeks maturity, there is a chance that with good advanced, extremely well neonatal care, we still have a chance that we can get that baby to survive. But if I don't act at timely, then the chances are that I may lose the baby. I've already discussed in this video, we will be discussing about the uterine artery Doppler. But let me first tell you why as a doctor Doppler is important. Doppler can tell me, yes, this patient is having problem. So I can advise the dietary changes to that patient. I can advise the lifestyle changes to that patient. I can prescribe some medicines to decrease the chances of complication, to mitigate the chances of complication. It can help me plan a delivery in time. In short, Doppler tells me a picture of a complete fetal well-being. I would not go into the details, the physics of Doppler, because that is a very, very vast subject. But what I would tell you is, there are three modes in Doppler. One is a color mode, one is a pulse wave Doppler, and another is a power Doppler. In color mode, in anybody of you who have gone an ultrasound, they just put a triangle, and in that there is a red and blue. Red means that blood flow is coming towards the probe, and blue means that blood flow is going away from the probe. Red does not mean arterial flow, blue does not mean venous flow. The only thing is it shows the direction. So I can localize the flow, I can locate the vessels, I can also diagnose some congenital vascular anomalies if they are there. But most important to us is pulse wave Doppler or a spectral Doppler. It can help us calculate the resistive index, pulsatility index, peak systolic velocity, all those kind of things. It can let us know. And in last 10-15 years, there is something called as a power Doppler. It is also called as a Doppler angiography. It is available. It is visualized as a orange, red on the screen. It just signifies the magnitude of color flow. It won't tell us the direction. But these three are complementary and these are very, very helpful to us. Now, many of the questions in our OPD come and ask us, sir, is ultrasound safe? Do I need to get Doppler sonography done every time? European Committee for Ultrasound Radiation Safety has maintained that ultrasound is absolutely safe. We do something called, we maintain always, anybody who is doing ultrasound, they always maintain, we follow a LRA principle, as low as reasonably achievable. The radiation emitted or the heat emitted by a Doppler probe is almost minimal, Having said that, we start an ultrasound, we keep with a B mode only. We use power Doppler and color Doppler only when it is necessary. That is also at the minimum output settings and for the minimal time possible. So as far as the safety of an ultrasound is concerned, please be rest assured, it is better than using this mobile. The amount of radiation emitted by mobile is far more than the amount of radiation which the ultrasound probe might. And we always work on a cost and benefit analysis rather than the risk and the effect ratio. What I get from doing a Doppler is far, far, far more than what I may miss if I do not do a Doppler. So now I come to the main topic of the video. What is utero-placental circulation and how does it help in making my decisions? As I have said earlier, this is the uterus, this is cervix, this is vagina, this is ovaries. Now uterus is supplied by the uterine arteries. Uterine arteries are the branch of anterior division of antenatal artery. And this uterine artery, some part of the blood circulation also comes from the ovarian artery. They anastomose and form an arcuate arteries. These arcuate arteries run circumferentially around the uterus, and from arcuate arteries arise the radial artery which go perpendicular inside the myometrium. And this is where the story begins. Now these radial arteries, they go deep inside and they form the spiral arteries. These spiral arteries in a non-pregnant uterus, they supply the endometrium, and those who are doing infertility, they would well know that there are 4 zones of endometrial. The more deep the spiral artery flow is, the better the chances of conception are. Now there are about these spiral arteries, they nourish the outer myometrium, decidua, and the intervillous space. There are about 100 functional openings of the spiral arteries into the intervillous space in a mature placenta. But in fact, the maternal blood space enters the space in discrete spurts, and only few of these arteries are required to permit the 10-fold increase in the uterine blood flow, which is necessary to meet the respiratory and the nutritional requirements of fetus and placenta. Now these basal arteries, again I am telling you, these basal arteries and the inside decidual arteries, the spiral arteries, these basal arteries, they do not undergo any change in pregnancy. But these spiral arteries, they are invaded by cytotrophoblast and they are converted into utero-placental arteries. Please listen to it carefully. Spiral arteries are invaded by the decidual, the cytotrophoblast cells, and are converted into the utero-placental arteries. These utero-placental arteries are dilated, sinusoidal. They do not have any elastic or muscular tissue. They do not have a continuous endothelial lining. They do not have mural thrombi and fibrinoid deposition. This conversion of spiral arteries into the utero-placental arteries is called, because of the cytotrophoblastic invasion, is called as the physiological change, and it occurs during the first trimester. The main purpose of this conversion is to convert the high resistance uterine artery circulation into a low resistance utero-placental circulation, so that because the demands of fetus and placenta would increase, it would require the increased uninterrupted blood flow from the mother to the fetus. That is why God has made this physiological change to convert a high pressure circulation into a low resistance circulation, and this is very, very important. This change makes a utero-placental artery, spiral artery, which has got a normal diameter of 15 to 20 millimeter to about 300 to 500 millimeter diameter. The increase in the diameter of the utero-placental arteries is to optimize the feto-maternal circulation, and this decrease in the circulation, this decrease in the impedance of the utero-placental circulation continues from 12 weeks till the last trimester. Initially, this decrease is on the side on which the placenta is implanted. The other side would be having an increased resistance, but the side on which the placenta, either right side or left side, whichever side the placenta is implanted, it would be having the less resistance. But later on, because of the development of the collaterals and because of the persisting hormonal change, ultimately both the uterine artery resistance would decrease. Impaired cytotrophoblastic invasion or improper conversion of spiral arteries into a utero-placental circulation, it can help us predict the chances of fetal growth restriction, severe preeclampsia, and placental abruption in future. And that is where the uterine artery Doppler comes into picture. When do we do uterine artery Doppler? I have discussed in my earlier videos. Again, I am discussing. The first opportunity when we get to do a sonography is at 12 weeks level. A good radiologist or a good fetal medicine specialist was always give us a uterine artery PI and uterine artery RI. Bilateral or a mean uterine artery PI, if it is more, if the percentile is more, that would suggest to us that this patient is more likely to have increased chances of preeclampsia, that means increased blood pressure in pregnancy, increased chances of fetal growth restriction, that means a baby which is less than the normal size, and increase in chances of placental abruption, that means placenta may separate from the uterus before the delivery, and that would decrease in the blood supply to the baby and bleeding through the vagina, and that may result in a medical catastrophe. After 12 weeks, we get another chance to do a sonography at about 20 weeks and 24 weeks. It has been found that if the uterine artery RI is more than 0.57 at 20 weeks, there is about 64% chances of that pregnancy ending up in pregnancy-induced hypertension or preeclampsia or increased blood pressure in pregnancy. There is also a 44% chance that this pregnancy may end up in fetal growth restriction. That is, the growth of the baby would be less. So in those pregnancies in which the uterine artery RI is more, we again repeat a Doppler at about 24 weeks and repeating uterine artery Doppler at 24 weeks. If there is more than a 95th percentile increase in uterine artery RI, or there is a presence of a bilateral notch, that would definitely increase the chances of severe preeclampsia or fetal growth restriction. Now comes my role as a gynecologist. If the 24 weeks RI is more, what do I do? If 20 weeks uterine artery RI is more, what do I do? If 12 weeks RI is more, what do I do? Again, let's assume that patient is with me from the starting and I have sent the patient for an NT scan. I get a report that there is an increase in uterine artery RI, which is suggestive of that this patient might end up in fetal growth restriction or severe preeclampsia. I would evaluate the patient as a whole. I would start low dose aspirin. Earlier people used to start 75 milligram aspirin per day. Nowadays the recent Cochrane studies have come and they suggest that you need to start aspirin at 150 milligram per day, and this 150 milligram per day, it not only improves the uterine artery flow, it improves the Utero-placental circulation and it decreases the chances of severe preeclampsia significantly. The chances of severe preeclampsia in patients who are taking aspirin are 2% compared to the 19% who are not taking low dose aspirin. The chances of fetal growth restriction occurring are also decreased. They are about 15% who are taking aspirin compared to about 25% who are not taking aspirin. I normally use low dose aspirin. I have made a video on low dose aspirin also. Please go and have a look at it. I normally start aspirin low dose 150 milligram in every patient irrespective of the Doppler, because what I have found is most of the patients have at some level some kind of undetected, undiagnosed subclinical level of autoimmune phenomenon in their body, and autoimmunity ultimately leads to the formation of increased microthrombi, that is aggregation of platelets, and to decrease that, ecosprin or a low dose aspirin works wonders. I also at that point of time 12 weeks take an opportunity to tell the patient, to sensitize the patient that this is going to be a high risk pregnancy, and so that they can modify their lifestyle and diet accordingly. So what in diet, there are always 4 things which are important. You need to avoid anything which has got refined carbohydrate, which can increase the glycemic index, because the more the glycemic index is, the more there would be inflammation in the body. The more inflammation in the body, the more chances of autoimmunity and fetal growth restrictions would be there. So I always ask my patients to avoid potato, to avoid sugar, to avoid anything made from maida, and to avoid wheat, because I don't want gluten to be in their body. I tell them that their diet should be rich in fiber, all kinds of green leafy vegetables like beetroots, like carrots, like spinach, like cucumber, like tomato, which also has got enough antioxidants. They should be taking diet which is rich in protein. Protein is very, very important for increasing the fetal weight. Protein is also very, very important to decrease the edema in the body. Anything made from protein like pulses, grams, sprouts. If patient is a non-vegetarian or vegetarian, patient can have boiled eggs, patient can have fish. But according to me, mutton and chicken, they are not that good as far as the protein intake is concerned. Fish is an excellent source of protein and it also gives an omega-3 fatty acid. Suppose the same patient comes to me for the first time at 20 weeks or at 24 weeks. Then what do? I'll continue with the same things. One thing I may add, at 12 weeks, I also start sildenafil citrate, Viagra. Yes, you heard it right. Viagra, 25 milligram to 50 milligram. There have been various studies. Stridal trial is one of them. Various studies, they are there. Basically, nitric oxide is a vasodilator which is secreted from the endothelium, the inside lining of the blood vessels of the vessels, and it is a potent vasodilator. It is a potent anti-aggregator of platelets. In preeclampsia, this nitric oxide decreases. So if we give a directly nitric oxide or a nitric oxide donor, in those cases, there are chances that there may be a vasodilatation, and because of that vasodilatation, the blood pressure decreases, the blood flow to the placenta and the umbilical cord increases, and we may be able to give good amount of oxygen-rich blood and the nutrients to the baby, so the growth may increase and we may be able to pull on the pregnancy for a bit longer. So it improves not only the fetal aspect, it also improves the maternal aspect. So there would be a decreased blood pressure. They will be able to pull on pregnancy for a bit, couple of weeks longer, so that there are more chances of having a healthy baby or a healthy mother. So that is where the sildenafil and the L-arginine comes. Sildenafil citrate is a nitric oxide donor. It gives vasodilatation, but sildenafil does not have to be taken orally. In females with high uterine artery resistance, we give 25 to 50 milligram sildenafil citrate to be kept vaginally, and I normally prefer from 12 weeks till about 30 weeks. That is the duration. I do not give sildenafil after 30 weeks. If cost is not an issue, I also add L-arginine either in tablet form or in sachet form, because that also causes generalized vasodilatation. It also causes nitric oxide increase in the body, and that supports in the management both of decreasing the blood pressure and to help baby in achieving the good fetal growth. So in conclusion, there is also one thing which I normally do. If it is a high risk pregnancy, patient has a past history of bad obstetric history, multiple abortions, multiple miscarriages, IVF conceived pregnancy, twins pregnancy, previous past history of intrauterine fetal death, previous severe eclampsia, at 24 weeks, if I see that this patient is having an increase in the uterine artery resistance, or there is a persistent of uterine artery notch, I know from my experience that this pregnancy is not going to be pulling on for more than 5 to 7 weeks. At 29, 30, 31 weeks, either the blood pressure is going to increase or severe oligohydramnios. I also add low molecular weight heparin to that patient, 40 milligram or 60 milligram depending upon the weight of that patient. There are various studies which say increase in the uterine artery resistance is an indirect indicator of APLA, antiphospholipid syndrome. So even if antiphospholipid syndromes are there are various causes of false positive, false negative. If you have to document a case of a antiphospholipid syndrome, there should be 2 clinical evidences or 2 laboratory evidences 12 weeks apart. But in a pregnancy which is precious, I don't have time to wait for 12 weeks apart. If I get a first reading of uterine artery Doppler which is high at 24 weeks, and if patient has a high risk, I start low molecular weight heparin, 40 milligram or 60 milligram depending upon the weight of the patient, to be taken subcutaneously daily on abdomen. And believe you me, it helps me in prolonging the pregnancy. If I had not given heparin, the pregnancy would have automatically, I would have to terminate the pregnancy at 28, 29 or 30 weeks. Heparin gives me a cushion of 1-2 weeks extra, and those 1-2 weeks, they mean a world to the baby which is inside the uterus. Even if I can pull on baby pregnancy for another 2 weeks inside the uterus, that pulling on pregnancy is worth more than a month in an ICU. So I would not only be increasing the chances of fetal prognosis, neonatal prognosis, I would also be giving a better financial incentive to the patient, because one day in an ICU, a preterm baby costs about 10 to 20,000 rupees per day. The moment I can save 15 days in an ICU, I'm easily saving about 2 to 3 lakhs of the patient. So in conclusion, I would like to say, increase in uterine artery Doppler, especially at 20 weeks, it signifies that there is chances of severe preeclampsia. It does not tell us about the risk of mild preeclampsia. It also tells us about the chances of severe fetal growth restriction, less than percentile, not mild fetal growth restriction. So if at 24 weeks uterine artery PI is more, that means we have to do a Doppler frequently. It also tells us how our ANC should be. If 18-20 weeks uterine artery Doppler is normal, then we have to again repeat Doppler only at 30 to 34 weeks. In between, we do not have to repeat the Doppler. But if 20 weeks or 24 weeks uterine artery Doppler is abnormal, there is high resistance, that means we have to repeat every monthly till about 28 weeks, 30 weeks, and then every 15 days. And then after that, the focus shifts to the umbilical and the fetal Doppler, which I will discuss in the next video. Please like the video, please share the video, please subscribe. And if you have got any comments regarding this, you can write in the comment section. Thank you. Bye-bye.